And then I can ask you all to mute when you're not speaking, please. Okay, should we admit everyone, Alana? And then I can ask you all to mute when you're not speaking, please. Okay, should we admit everyone, Alana? Are you hearing that, Alana? That's the live stream. And then I can ask you all to mute when you're not speaking, please. Okay, welcome everyone. We're very excited to have you on this very first session for Foundations in Critical Care. Feel free to introduce yourself in the chat. We're going to go ahead and get started. We also have a Q&A feature. So if you have questions about the presentation for the panelists, please use the Q&A feature at the bottom of the screen. So welcome to the Foundations in Critical Care. This is session 1 of 12. This session or this series will start this November and will run for 12 months. Topics are chosen based on a global survey of bedside providers. So these are the topics that you found to be most relevant and important. So this is session 1. Today we're going to talk about distributive and septic shock, and I'm very excited to introduce our panelists. My name is Dr. Anna Maria Crawford. I'm an anesthesiologist and intensivist at Stanford. Dr. Yao Kusi-Mensah is an anesthesiologist and intensivist in Ghana. Dr. Sebastian Mojar is at ABC Hospital in Mexico City. He is also an anesthesiologist with some critical care training and is soon to do a fellowship in transplantation medicine as well. Dr. Fred Meem is a mentor to me, an intensivist and anesthesiologist at Stanford University. Dr. Joel Toshi is an anesthesiologist, also pursuing further training in critical care medicine in France, but his home country is Cameroon. And the Honorable Dr. Ron Pearl, another mentor to me and a previous chair at the Department of Anesthesia at Stanford University, a renowned intensivist and anesthesiologist also. A few housekeeping and etiquette tips. This is a respectful environment for learning. It's supposed to be a safe place for all individuals from various backgrounds to learn together. So please respond kindly if you disagree with something. Learning, we will be using the Q&A or question and answer function that can be found at the bottom of your screen. Please send questions through the Q&A box and feel free to introduce yourself in the chat. If your bandwidth permits, you're encouraged to turn on your video to capture your face or the room if you're in with a group of people. This session is being recorded. Your attendance is your consent to be recorded, and this session will be posted on the Learning Resource Center, which we'll tell you more about, and will also be live streamed on YouTube. We should be live now. Closed captioning is available, especially for those whose first language is not English. This may be helpful in understanding our panelists and speakers. So feel free to turn on closed captioning, which can also be found at the bottom of your screen in Zoom. The Learning Resource Center is online. This online platform hosts all of the materials you will see today. On the LRC, you can find the slides, you can find the slide notes, and you will also find a resource library that has all of the materials available from today. So you can scan the QR code here, and I will also put the link to the LRC in the chat. This webinar series has CME credits that are awarded through Stanford University. You will receive an email within 3 days after, pardon me, you will within 3 business days with the link that is complete, that you will need to complete an evaluation in order to receive your CME. So look out for that email, and we will post this slide again at the end of today's presentation. So this session is part 1 of a 4-part series on shock. According to UpToDate, shock is defined as a state of cellular and tissue hypoxia due to either reduced oxygen delivery, increased oxygen consumption, inadequate oxygen utilization, or a combination of these processes. Because circulatory failure and inadequate oxygen delivery is the most common cause, we will be discussing these mechanisms of shock in this series. Shock is initially a reversible condition. However, if it is not recognized and treated early, it rapidly becomes life-threatening and leads to multi-organ failure and death. Shock can be described in 4 categories: cardiogenic, obstructive, distributive, and hypovolemic. We will cover each of these categories in separate sessions. We will refer back often to this one-pager called the Approach to Undifferentiated Shock. This one-pager is available for download on the Learning Resource Center, or you can scan the QR code here to access it directly. It's important to remember that many patients have multifactorial shock. For example, a patient may have distributive shock from sepsis, but also has a cardiogenic form of shock as well. So it's very important to recognize and treat both simultaneously. Today, we will focus on distributive forms of shock. Distributive shock is also known as vasodilatory shock and is associated with a decrease in the resistance of the blood vessels or a decrease in the systemic vascular resistance, or SVR. If you think of circulation as pumps and pipes, this is a pumps problem or a pipes problem. So you can see that we're talking about distributive shock in the blue boxes on the one-pager for your reference. As a refresher, let's quickly talk about blood pressure. Oxygen is delivered to cells by circulating blood. Because we cannot measure oxygen, circulation, or blood at each and every cell in the body, blood pressure is the best substitute to measure blood perfusion to the cells. For the next 4 sessions on shock, we will discuss blood pressure with the understanding that it is created by the product of cardiac output and systemic vascular resistance. Cardiac output and systemic vascular resistance are the pump and the pipes idea. Cardiac output is generated by the heart. Look on the left column of this slide. It's equal to the volume pumped out of the heart in 1 minute. It is measured in liters per minute. This volume is determined by the stroke volume of the heart multiplied by the number of heartbeats. Stroke volume, or the volume of blood that leaves the ventricle during contraction, is the result of preload, the contractility of the heart muscle, and the afterload. The pipes, or systemic vascular resistance, is the force or resistance that is exerted on the circulating blood by the blood vessels. This resistance is determined by the length of the vessels, the diameter of the vessels, and the viscosity of the blood. SVR is also a force the left ventricle must overcome to pump the blood out of the heart and into the aorta and the rest of the arteries. Today, again, we are discussing distributive shock. As we move through this discussion, it is important to remember that shock is a life-threatening condition. It is a medical emergency. Shock is most commonly associated with circulatory failure that results in inadequate oxygen delivery to the cells. Inadequate oxygen delivery results in cellular and tissue hypoxia. This can lead to cell death, to tissue death, and organ dysfunction. If it is not reversed quickly, shock becomes fatal to the patient. Through this case-based discussion on distributive shock, we hope to achieve the following objectives. You should be able to recite the equation for blood pressure. Blood pressure is equal to the cardiac output times the systemic vascular resistance. You should be able to list the 4 categories of shock. Today we're talking about distributive shock. We'll also talk about hypovolemic shock, cardiogenic shock, and obstructive forms of shock. We should be able to identify shock as a medical emergency, a life-threatening emergency for patients. We should be able to describe the characteristics of distributive shock and recite the common causes of distributive shock. We need to be able to recognize the signs and symptoms that are specific to distributive shock. At the end of this, we should also be able to define sepsis and define septic shock and understand the treatment of sepsis and the goals for management in adults. We should also be able to list the primary treatment goals for other types of distributive shock, such as anaphylactic shock, neurogenic shock, and adrenal shock. Please note that although we will provide resources for the management of pediatric shock, this will not be discussed today. So with that, I want to introduce our patient. Today, our patient is Mr. G. You are working in a rural district hospital. The nearest hospital with an intensive care unit is 20 kilometers away. The physician working in the emergency room calls you to come and examine this patient that she wants to admit to the hospital. Mr. G is 76 and he's had 3 days of diffuse abdominal pain with blood-tinged diarrhea. He has nausea and he's had 5 episodes of vomiting or emesis. He describes weakness and he stopped eating and has not gone to work for 2 days. Mr. G has a respiratory rate of 32, a heart rate of 108 beats per minute. His blood pressure is 89/49 with a MAP of 62. Temperature is 38.5 degrees Celsius, and his oxygen saturation on room air is 90%. Mr. G is placed on 3 liters per minute of oxygen therapy by nasal prongs. His SpO2 improves to 95%. With that, we'll have Dr. Sebastian talk about shock and its epidemiology.
So good morning, everybody, and welcome. So today we're going to talk about, as Anna has already told us, about shock. And when we talk about shock, we have to first understand how it is distributed and what are the percentages. Now, bear in mind that these percentages that we are going to talk about is from where we have more data, and that is from high resource settings. The most common form of shock presenting is septic shock. One study, the etiology was up to 62%, followed by equivalently from cardiogenic and hypovolemic shock with 16% each. And there are other causes of distributive shock as well that can contribute to up to 4%, thinking about anaphylactic shock, and to a lesser extent to a 2% responsible for obstructive shock. It is important to note 2 things. The etiology and the percentage of shock varies by settings. For example, if your hospital is more accustomed to receiving trauma patients, then the hypovolemic or hemorrhagic shock might be a lot higher than those from another type of settings. And what is unfortunate is that these data are more related to higher resource country, and the lower or middle income resource countries are harder to identify. It is unknown, or it is very variable, since there's not enough data to be able to have these definitions. So it is this epidemiology is challenging to describe in these type of lower resource settings. For the next slide, Doctor, please. And now, having this in mind about the complexity of knowing what is the distribution of sepsis, septic shock, and shock in general, there was a very interesting study that you can if you scan the QR code, you can easily obtain, and it's also in the platform that we mentioned earlier in this session. This study used a very interesting technique to try to identify what was the distribution of sepsis throughout the world, and it based itself in two strategies, using where available electronic health records and were not available, using death certificates throughout more than 180 countries. And with these two, they were able to analyze what the incidence was of sepsis and the incidence of mortality was as well. So the map that you have on the upper part of the slide talks about what's the incidence. As you can see, the deeper blue countries are the ones that have a higher incidence or suspected higher incidence of sepsis. And on the lower map that we can see is the incidence of, or the death toll related to sepsis. So again, those countries in lower or middle income, resource or developing are the ones that have a higher incidence of sepsis and a higher incidence of death related to sepsis. Then this just kind of emphasizes the importance of being able to identify quickly, be able to do the first steps of management, and be able to avoid these deaths.
Wonderful. Thank you so much, Dr. Sebastian. So back to our patient, Mr. G reports he has a history of high blood pressure or hypertension, but he does not take any medications. He's not had any previous surgeries. He's married with 3 adult children, but he does not smoke alcohol, smoke cigarettes or use alcohol. On physical exam, Mr. G is drowsy but awake with a non-focal neuro exam. His GCS is 15. His heart rhythm is regular but tachycardic. His breath sounds are coarse bilaterally. He's breathing quickly but is still able to speak in full sentences. His abdomen is soft but tender to palpation, especially in his lower quadrants. There's no rebound or guarding, and his liver edge is not felt. His capillary refill time is 3.5 seconds, and he has no edema in the peripheries. Mr. G is 181 centimeters tall, and he weighs 70 kilograms. The emergency medicine physician starts an 18-gauge peripheral IV in order to give intravenous fluids. Lactic acid or lactate, full blood count, a complete metabolic panel, transaminases, and a coagulation panel have all been drawn and sent to the lab. A portable chest X-ray was also ordered, but is pending. So with that, we're going to let Dr. Joel talk to us a little bit more about the physical exam that you can find in shock.
Thank you, Anna. Next, we'd like to explore the clinical presentation of shock. It is good to see a patient with shock can present with a lot of signs and symptoms. It can vary from hypertension, tachycardia, fever to hypothermia. The list is quite exhaustive, and none of these signs or symptoms are specific nor sensitive for shock. As such, there is no pathognomic sign nor symptom for shock. Most signs are related to hypoperfusion to tissues and organs. Identifying some symptoms or signs like metabolic acidosis and hyperlactatemia can be quite difficult in some resource-constrained environments due to the scarcity as well as the non-availability of blood gas analysis. But it's always important to always have it at the back of your mind that a patient with shock can present with metabolic acidosis or raised serum lactate level due to hypoperfusion to tissues or organs.
Thank you, Joel. If you could please. I think it's really important for us to remember the etiology of shock. The cause of shock is usually decreased perfusion. So a lot of these physical exam findings make sense when you have low blood pressure and decreased perfusion to the cells. Can you tell us, Dr. Joel, what is the difference between warm shock and cold shock?
Thank you, Anna. This question is particularly very important. It's actually very high yield. It's important to always differentiate between warm and cold shock. If you have any suggestions, answers are welcome in the chat box. But we'd like to say, that these terminologies are more related to the natural disease of shock rather than the subtypes or the different types of shocks, such as cardiogenic or septic shock. So at the initial stage of shock, a patient is going to present with warm extremities, suggesting vasodilatation and increased perfusion to the peripheries. As the shock progresses and the patient is not attained, so he's not given treatment, the extremities become cold, reflecting aggravation of the hypoperfusion, with distal extremity becoming vasoconstrict and cold. So warm shock and cold shock, there are more terminologies aiming to describe the natural disease of shock.
Yeah, so I think sometimes people will think about distributive shock, especially septic shock, as associated with vasodilation, so that the patients may initially have warm extremities. But really, that's a temporary thing. And as the shock progresses, they start to vasoconstrict again to try to raise their blood pressure. Dr. Mim, do you have any comments about that? And can you tell us a little bit more about the different types and characteristics of distributive shock?
Sure. This diagram here gives a really nice overview of different types of distributive or vasodilatory shock. Again, this is a pipes problem where there's inappropriate vasodilation. And if you look on the left-hand side, you'll see systemic inflammatory response versus other causes of low SVR or vasodilation on the right. I'll just spend time on the left for a moment, because the most common cause of systemic inflammatory response is infection. And when it causes this kind of a problem, it's a systemic infection. It may have started someplace, but now it's spread. And you can also see under systemic inflammatory response, the non-infectious causes, which you have to keep in mind if the clinical presentation suggests that. And those things include pancreatitis, severe burns, embolic syndromes, particularly amniotic fluid embolism, fat embolism. And you can also see it in a post-cardiac arrest patient. But if we had these, this diagram was sized to the proportion of patients that have distributive shock. The systemic inflammatory response would be very big, and infection would be also very big, because that, as you heard earlier, is the most common cause of distributive shock. And you're also on the right-hand side now for other causes of low SVR or vasodilatory shock. You can see anaphylaxis is one, neurogenic causes that from severe brain injury or spinal shock, endocrine causes, you might see that from adrenal insufficiency or carcinoid crisis, maybe even a pheo crisis and infarction, and other medications and toxins can cause this as well. So this is a good overview of what you should be thinking about when you discover someone with distributive shock. But your suspicion is that it's probably infectious.
Thank you, Dr. Mame. I love that you made that point, because septic shock is what we see the most often as the cause of distributive shock. And in fact, that's why we designed today's webinar to spend the majority of the time on sepsis and septic shock, even though we will talk briefly about the other forms of distributive shock. And for those in the audience, I think it's important for you to know that Dr. Mame is a worldwide expert on pheochromocytoma, so knows a lot about the function of the adrenal gland. So thank you so much for pointing those things out. Back to Mr. G. He has fever, he's hypotensive, he has tachycardia and tachypnea. He also has nausea and vomiting with bloody diarrhea. This is the summary of what we know so far. Based on his history, his symptoms, and physical exam, and what you've learned from Dr. Meme, from Dr. Sebastian, and Dr. Joel, we're starting to be concerned for shock, and we're starting to be concerned that he might have an infection in his abdomen. So you begin to start suspecting septic shock. So with that, we're going to go back to Dr. Mohar and talk a little bit more about sepsis and septic shock and what that means.
Thank you, Anna. So pinning down or going into this is septic shock, it's a good moment to talk about what is septic shock and what are the efforts that are being done in order to identify, treat, and what are the available resources. As well, these are the 2 QR codes, and these are very important resources that you can get from the QR codes and also from the LRC platform mentioned above. And when we talk about the Surviving Sepsis campaign, this is an international guideline, and it's led by a coalition from the Society of Critical Care Medicine and the European Intensive Care Medicine Society as well. So these campaign conducts and research, and what it's looking is to create and compile guidelines, including the most recent updates, including the most recent article that is being published regarding sepsis and regarding sepsis treatment and management. It's compiled and they come out with recommendations. The last one that came out was in 2021. Generally, there are management guidelines for adults, pediatrics, and even COVID. Today, we will not be talking about the pediatric shock, but the resources are available, and with this QR can get them. These clinical guidelines and recommendations are always available online and have become kind of what is the guiding light when you come around these type of patients, which are easy, manageable, and they give options depending on where you are and what options your facility has. It's very important to have this at the back of your pocket, to have them in your phone, to have them wherever accessible in order to be able to make quick decisions when. Next slide, please.
Yeah, if I could just make one comment, I think these guidelines are certainly very, very helpful.
Yes.
I also think in years past, we did not do a great job compiling guidelines with considerations for resource-constrained practice settings. The 2021 guidelines for adult sepsis management has improved significantly in considerations of resource constraints. So I think it is important for us to recognize past guidelines and future guidelines may not always consider practice settings that have constraints in the resources, but we're definitely doing better as time goes forward.
All right. So what is sepsis and what is septic shock? We might just give a minute for everybody to put the definition of what they understand as these two.
Dr. Moha, you're breaking up a little bit on my end. I'm wondering if your video is taking some of your bandwidth, if you want to turn your video off, perhaps.
Yeah, maybe is that better, Dr. Crawford? Yes? Is
Yes,
this better?
I think so,
or is it
yes.
still breaking up?
You sound great. Thank you.
Okay.
Let me know when you're ready to reveal the answer, Dr. Sebastian.
Yes, so maybe we can go for the next. So this is the it was published back in 2006, and this is a consensus to define these two entities that were mentioned that we're going or been talking about in the last couple of slides. So sepsis should be defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. Septic shock should be defined as a subset of sepsis in which particularly profound cellular and metabolic abnormalities are associated with a greater risk of mortality than alone. Patients with septic shock can be clinically identified by the Vasopressor requirement to maintain a mean arterial pressure of 65 millimeters of mercury or greater, and the serum lactate over level greater than 2, and in the absence of hypovolemia. So this definition is accepted through the community, and experts from different parts, from the physiological, from the clinical settings, from epidemiologic settings, got together in order to be able to give these two definitions and be able to identify quickly when we have these clinical settings.
Thank you so much. Unfortunately, you broke up just a little bit, so I'm going to just summarize for folks who were unable to hear you that sepsis is a dysregulated response of the patient's body to a source of infection. And septic shock is sepsis, but you also have hypotension or low blood pressure. And that's usually defined as less than 65 millimeters of mercury. Or you can also have a serum lactate or lactate level that is greater than 2 millimoles per liter or 18 milligrams per deciliter. In the absence of hypovolemia, so the patient's received adequate volume. One common question I get, even from our trainees at Stanford, is how do you recognize and identify somebody with shock and septic shock? And I'm wondering if, Dr. Pearl, you would mind reviewing some of the things that are available to us to identify patients with sepsis and septic shock.
Yes, thank you, Dr. Crawford, and thank you for organizing this webinar. This is a question which was submitted by one of our learners. I want to just remind people that if you have questions that you'd like to get answers to during this webinar, the Q&A box at the bottom, just click on that and enter your questions, and we and the audience here will try to provide the best answers for that. So this definition of sepsis and of septic shock that you saw on the previous slide can be sort of confusing to translate directly into whether your patient has sepsis. And so what you need to do is really combine that with the patient's signs and symptoms to give you a suspicion that the patient may be suffering from sepsis and septic shock. Sepsis being obviously an infectious source. So in addition to what Dr. Crawford reviewed just then in terms of looking at blood pressure and lactate, they have developed different clinical scoring systems that can be used to screen large numbers of patients to quickly identify those patients who may be developing sepsis, septic shock. And the ones which are commonly used are shown here. SIRS, which has been with us for many decades, and the newer ones, the Muse, NEWS, and NEWS2 scores. And these are really both detecting sepsis, septic shock, but also recognizing patients who are likely to quickly decompensate and become critically ill. Each of these scoring systems uses vital signs to assess the overall condition of the patient. They can be readily, easily calculated in some places where you have a continuous electronic system that will calculate them and notify people, but they can also be relatively quickly calculated by hand, or if you have a smartphone available. And they're used really to tell people that the patient may be developing. They're not necessarily diagnostic of sepsis and septic shock. At the bottom here is the comment about the Q-SOFA score. The Q-SOFA score was developed as a very, very simple system. It only has 3 components, and you get a point for each of them, one being that the Glasgow Coma score is not normal, it's less than 15. Second being a respiratory rate of 22 or above. The third being a systolic blood pressure of 100 or below. But it has not proven to be very useful in the emergency room or in the ICU, and no longer recommended because it's got really a poor specificity and poor sensitivity, and thus we no longer are using it. Instead, these somewhat more complicated systems that are much more accurate for letting us know what is going on.
Dr. Pearl, I think the Q-SOFA is still very commonly used and recognized. And I wonder about this recommendation of not using it as a single screening tool. I think it's important to point out that you can use Q-SOFA, but if you do, you may miss some patients because it's not sensitive enough. So if you're going to use Q-SOFA, maybe consider using it in combination with one of the other early warning scores, or switching over to one of these other early warning scores. Would you agree with that statement?
I would. It was developed for screening large numbers of patients. It's not very useful in an individual patient, both sensitivity and specificity wise. So, I would try to use one of these. SIRS is very simple. It has some of the same issues of many patients have abnormal SIRS scores, but they don't have sepsis or septic shock. The Muse and the News 2 are much more specific for sepsis.
Yeah. So I like your comment about using your smartphone. There's a lot of calculators that are apps that you can download to do some of these calculations if you can't remember what's involved. Thank you, Dr. Pearl. Can you tell us a little bit more about how we manage sepsis right when we suspect it?
Yes. Once you've diagnosed or believe the patient has sepsis and septic shock, it's important to start treatment early. There's some debate on how fast you need to do certain things, and some of that debate is very appropriate in this setting because the initial recommendations for some of these were to do it very quickly in the first hour. That was felt not to be able to be done in some settings. But there's consensus that the important aspects are rapid antibiotic administration, initiate fluid resuscitation, and then admitting the patient to the ICU. If you look here, you've got 5 steps outlined. The recommendation is to draw blood and measure the lactate level. As was mentioned, an elevated lactate is a sign of septic shock. And importantly, if it starts off high, you want to follow it and see it coming down so that you know your treatment is being effective. At the same time, to get blood cultures, and these should be obtained before antibiotics so that the antibiotics don't prevent being able to identify infection and the specifics of what that infection is, and then administer broad-spectrum antibiotics. And ideally, this should all be done within that first hour of diagnosis. You can then start to begin rapid fluid administration. In general, the recommendation is 30 milliliters per kilogram. Crystalloid is the fluid of choice. And to give that 30 mils per kilo, basically in an adult, that's 2 liters of fluid within the first 3 hours. And if the patient is hypotensive, continues to be hypotensive, lactate doesn't come down, to continue more fluid administration beyond that amount. And finally, to rapidly restore blood pressure. If the patient did not quickly respond to fluids, to start the use of vasopressors. And there's abundant evidence that the goal for blood pressure we're looking at is going to be a mean arterial pressure of 65 or higher. Studies have not indicated that a higher pressure is of any value and does end up requiring significantly more vasopressors.
Wonderful. Thank you so much. I'm already anticipating some of the questions from our audience, and that is, what do you do if you don't have access to lactate or lactic acid as a lab value? And I think my answer would be just to do the best that you can. Obviously, you can't check it if you don't have it, but you could still monitor the patient's volume status and blood pressure and treat with antibiotics in order to see improvement. Would you have any other comments or advice for people, Dr. Pearl?
Overall, I would agree. Part of what we're normally going to see with lactic acidosis, we're going to see acidosis. So looking at your blood chemistries, if you have looking at a blood gas in terms of base deficit, will give you some of that same information, though not as quantitative and as sensitive.
Some of our colleagues in very resource-constrained settings don't have access even to blood gas analysis, but they often have access to a metabolic profile. And so what would you see on the metabolic profile that would raise your suspicion for the acidosis you speak of?
Right, and I think I had included just the regular blood chemistries. You're looking for the serum bicarbonate to decrease, and you look for an anion gap calculated from the sodium, potassium chloride, and bicarbonate values.
Perfect. Yeah, that's what I would do as well. And then may I ask you one other question about obtaining blood cultures before giving antibiotics? How long would you wait to give antibiotics if you can't immediately check a blood culture?
I would say that, if the patient is progressing in terms of the level of shock, and for some reason I'm not able to get blood cultures, yes, I would go ahead and give them. The most important thing, and I think we'll have more discussion, is to be able to administer antibiotics early. All of the data indicates that even short periods of delay from giving an effective antibiotic significantly worsens outcomes. So if for some reason you're unable to give antibiotics, I would go ahead and administer them.
Yeah, thank you. I agree. And if I can press you with one more question, here I am challenging my mentor. Some people are using procalcitonin values, lab values, to help determine if there's an infectious cause. Would you wait for the procalcitonin value before giving antibiotics to a patient?
So the quick answer is no. I am a big believer in procalcitonin. Some people use C-reactive peptide. Both of those are biomarkers that basically are meant to identify whether there is bacterial infection. It's clearly much worse to not treat with antibiotics when the patient has a bacterial infection than it is to treat and the patient does not. It takes time. Where we are, it's probably going to, at Stanford, probably is going to take us an hour to get the procalcitonin back. We've already said we should treat. If you're not going to treat, you don't think the patient has sepsis, the procalcitonin may be useful to tell you to treat. It's most used in settings where the likelihood of bacterial infection is low. For example, a patient who you think may have a viral syndrome. It is useful, and if you look at the Society of Critical Care Medicine guidelines that we've referred to the Surviving Sepsis campaign many times so far, the recommendation is actually to use biomarkers not so much for deciding to start antibiotics, but for deciding when you can stop antibiotics later on when you're seeing an improvement in those biomarkers.
Thank you so much. I think that's really, really helpful and a source of confusion for some folks. I really appreciate that. Speaking of antibiotics, I'm wondering if Dr. Yao can help us with the next few discussion points about antibiotics.
Right. Thank you, Anne-Marie. And that's awesome. Just before I start, I want to just chip in about capillary refill time, the Andromeda trial. if you don't have lactate, for those of us in Ghana, you can use the capillary refill time, and that's actually good enough. The Andromeda trial spoke about no difference between CRT and lactate levels in direction of resuscitation. So you can't use the capillary refill time to help you, right? So that's one of the points I wanted to make. And I think we still use the Q so far because, again, we lack the resources. So I agree, like you have to do it in conjunction with other things, and that will kind of like point you in the right direction. Okie dokie. So I'm going to talk about antibiotics.
Thank you. Those are great points. And I love this panel because we have people from very high resource settings as well as resource constrained. So any of the tips you can share with how you manage things when you don't have the resources is incredibly welcomed. So thank you so much for that.
Yeah, I was actually impressed that you get your procrastinating in an hour. We'll never get it in an hour. It takes like days. That's quite impressive. Yeah, that's really impressive. So, I mean, just moving on. So we're going to talk about antibiotics, right? And those are one of the pillars in managing septic and septic shock. And when it comes to antibiotics, the key questions I always ask is the timing. How do you, when do you start antibiotics? When do you stop antibiotics? What antibiotics do you give? How do you give your antibiotics? The question of resistance and AMR, and all these nuances, as well as source control. So in the next couple of minutes, I'm going to talk about timing of antibiotics and how to kind of like give antibiotics in the treatment of septic shock. So when it comes to the antibiotics, right, you want to kind of know when to start. So the thing is, if you have a high index of suspicion that the patient has sepsis, you've gone through the criteria, you are it's very likely the patient has sepsis and the patient is in shock. By all means, within an hour, you need to start your antibiotics, right? And I'll talk about what antibiotics you start in a minute. If you suspect that they really have sepsis, but shock is absent, the guidelines still say that, again, you need to start within an hour, your antibiotics within an hour. Again, if sepsis is probable, and then it's like you still have shock, once the patient is in shock, one of the things I tell my registrars is that once the patient is in shock, it's better to start antibiotics than to sit and wait. But when you don't have, like, there's sometimes where the likelihood of sepsis is not so high, the patient is not in shock, then you can kind of have a bit of time to try and do further investigations to try and clarify and be sure that before you start antibiotics. But then again, it speaks to antibiotic stewardship. So in that case, within the first 3 hours, if you still after 3 hours, you still think it's likely to be sepsis, then you need to start your antibiotics. So those are when it comes to the timing of starting antibiotics. Next slide.
I just want to make one comment, if I may. I just think it's really important for everyone to recognize that even though it might be confusing when to start antibiotics, which antibiotic to start, how long to do it, it's incredibly important to use the resources available to you for good antibiotic stewardship, as this helps prevent resistant organisms and maintains the effectiveness of the antibiotics that we do have. So if there's no infection, then don't use antibiotics. But if you suspect sepsis, then do. And I just want to point out that this week is Antibiotic Awareness Week. So this is more information on antibiotics from the World Health Organization. You can again, scan the QR code to find more resources and materials for how to promote good antibiotic stewardship at your institution. Thank you for letting me interrupt you.
No problem, Anna-Marie. That's fantastic. Yeah, so once you are clear in your mind that you want to start antibiotics, then you want to know what type you need to start. So how do you choose your antibiotics in terms of what are the things that guide you in choosing your antibiotics? And I don't know if anybody has any input or ideas of how you choose the antibiotics. Anybody, any inputs in the chat? Anybody? How would you choose? Do you choose it based on race, based on, what are your thought process when you're choosing antibiotics?
We can hear from the panelists as well. I think I like to use Mr. G, our patient, as an example, and we're suspicious he has an infection, but he's also having abdominal pain and diarrhea. So I would like to consider the types of bacteria that would cause those types of symptoms. Yeah.
Fantastic. So you want to you're considering the area, the focus, the likely organism. It's like you're kind of trying to make your best guess when you're choosing antibiotics. So someone with abdominal symptoms, you're thinking of abdominal flora, right? So you're trying to think of covering like enterococcus, you're trying to cover those organisms that are likely found in the abdomen. So that's the first consideration, that you want to know where the likely source of infection is coming from. Secondly, you look at your patient characteristics. So Mr. G is an elderly man. You know, the physiology and the nuances in an elderly person is quite different from a younger patient. So you want to know the patient's characteristics. You want to know, does the patient have any other comorbidity? So someone who's diabetic has a different mechanism when it comes to sepsis. They have the more severe infection, and they are likely to have more resistant organisms. So you want to look at the comorbidities. You also want to consider things like if they're immunosuppressed, and the presence of invasive devices. And that's one of the things that, again, for me, that I work in the cardiac center, I have a lot of patients with pacemakers and stuff like that. And that kind of feeds into those aspects. Now, the next thing we want to think about, so once you have that in your mind, you want to do a broad spectrum antibiotic. You want to cover widely. You want to do an empirical treatment. And often the common choice is you want to cover for both gram-negative and gram-positive. And we look at specifically things like your beta-lactams. So your beta-lactams, you're looking at your third, fourth, fifth generation cephalosporins. You're looking at your penicillins, and we typically use peptides. If you're also going forward, you want to think about your carbapenems. So these are the broad spectrum empirical treatment, and that's what guides you in the choice. I think in the previous slide, we showed you the Wellington chart. That's kind of like a cheat code. So if you know clearly the organism you're dealing with, you can go straight onto that. Now, often than not, you are saddled with resistant organisms. And so you want to look at the risk factors. When you're choosing antibiotics, you want to know that this patient is likely to have risk factors that will let them have resistant organisms. So you want to look at the medical history. Again, you want to look at if they've taken antibiotics, or you have a patient who was admitted in a different unit or a different hospital prior to coming. You want to also see if they've had any hospital exposure prior to coming to you. And I've already spoken about medical devices and immunosuppression. So those are all risk factors, so that there's a high likelihood that the organism you're dealing with is a resistant organism. And so when you're choosing your antibiotics, you're thinking about resistant organisms. I hope that makes sense.
It does. I am going to
Fantastic.
ask you just to slow down just a little bit, because English
Okay.
is often like the third or fourth language for many of our learners. But I really appreciate your thorough presentation. So thank you.
Right. Okay. So I'm going to slow down. I apologize again for taking it quite quick. So we're going to look at resistant organisms, right? So when you have someone, and it's very likely for me in the ICU, I often have patients who have who are likely to have resistant organisms. Most of them have either been on the ward or either been in other facilities prior to coming. So for me, I'm always suspecting that my patients have resistant organisms. And a couple of resistant organisms that we deal with are, you have your MRSA, you have your VREs, which is your vancomycin-resistant enterococci, you have your carbapenem-resistant enterobacterialis, CREs, and CRE is a nightmare if you have to manage CRE. I don't know, for those of you on the panel, I hate managing CREs because the mortality is quite high. And then you have your ESBLs, your extended spectrum beta-lactamases, you have your CRABs, and then one of my consultants always talk about the CRABs and the CREs. And then you have your multi-resistant Pseudomonas. Again, Pseudomonas is a very difficult organism to treat. So these are the resistant organisms that you are often not going to treat. And therefore, you are choosing your antibiotics with these organisms in mind, right? Now, we are going to talk about certain key things when it comes to antimicrobial usage in the 2021 guidelines. And again, I like how Anna-Marie commented about the survival sepsis guidelines. In fact, it's our Bible for critical care. When my first few months, I was told to know the guidelines back to back. So those of us who are the fellows on the call, I recommend that you actually go through these guidelines, because it has a lot of information and details that would help you. Now, the first thing is that, okay, so you have someone who has sepsis, you decided to treat with antibiotics, you're trying to decide which antibiotic you want to give. You suspect that it's likely going to come from the abdomen. So you are wondering, what kind of antibiotic would I use? But then again, if you have concerns for MRSA, so you're thinking that if this patient is likely to have MRSA, so you have patients who have, skin lesions, or you have patients who have, implants, like, or devices, they're very likely to have MRSA, or they've been in the hospital for a while. So the guideline says that with those people with that high suspicion, it's better to cover for MRSA in addition to your empiric treatment. So your empiric treatment should include MRSA coverage. The second thing is that, but if the suspicion is low, then you don't need to add MRSA coverage in your antibiotic of choice. Next slide. The next thing is that the other thing on the guideline talks about when it comes to antibiotics is when you have someone and you're thinking of multi-drug resistant, in the critically ill, you typically want to have gram-negative cover, and you want to use two, for your empiric choice, you want to use two antibiotics instead of one. And the rationale is that you're trying to cover widely. So if you think that you have someone who has, like again, typically in our ICUs, you want to do multi-drug, you want to do two microbials, which cover gram-negative. And that's what the guidelines say. But if you realize that when you think that the suspicion of a low, it's not likely that they will have a multi-drug resistant organism, you can actually suggest that instead of using two, you should use one gram-negative antimicrobial agent. And now the other thing is that for adults with sepsis or septic shock, once you know the causative pathogen, like from the Wellington slide, you can then kind of like go more targeted approach. And that's all under antimicrobial stewardship. And for individuals with fungal infection, where you are concerned about fungal infection, the guidelines recommend that you cover for antifungal. So you have someone who is on TPN or who had abdominal sepsis, likely from a large bowel contamination. It's very likely that they will develop invasive candidiasis. So you want to also cover for antifungal in your empiric treatment. But where the suspicion of your index of suspicion of fungal infection is quite low, the guidelines say that you don't need to give that. And that's one of the things that the guidelines talk about. And it also says that the guidelines didn't make any recommendation about antiviral agents. And so you actually do it as you want. So one of the questions I want to ask the audience is, what is most important in the treatment of septic shock? List your number one priority. What do you think is most important in the treatment of septic shock? Okay, I see someone saying antibiotics. Okay, what else? I see more antibiotics. You guys like antibiotics. Okay, someone says source control, cardiovascular support. Okay, inotropic support, fluid therapy. Interesting. Nobody said anything about nutrition. Wow. Fluid therapy, I see hydration, I see fluids, eliminating infection, steroids. Wow. You guys are going big. Okay, so the recommendation is that you need to treat so if there's an anatomical source control is very important. I remember doing my fellowship, one of the things I used to have a fight with the surgeons about, source control. If you don't have source control, you can throw all the antibiotics at the patient, they would not survive. So the key thing is, if there's an obvious anatomical source control, you need to make sure that you get adequate source control. And then the other thing is that if you have invasive, so one of the things that we used to do in the ICU was that we change our lines. So take out all lines. And one of the things I learned from one of my consultants, if in doubt, take it out. So once you suspect, take out all the lines. It's better, yes, it's expensive, but it's better to take them out than to have the problems. And then one of the final things I want to talk about is, for adults with sepsis or septic shock, we suggest daily assessment for de-escalation. And that's one of the things the guideline talks about. De-escalation means that you are every day assessing if they need the antibiotics. So you're going through your treatment chart. You're seeing that, are you still giving to me? You have started, say, empiric peptides, and you've, over maybe day 3 or day 4, you realize that your blood cultures have given you a specific causative organism. You want to de-escalate to that. And every day you need to check that. Sometimes even after day 3 or 4, they are quite okay. You don't need to continue antibiotics. So that speaks to the timing when you stop your antibiotics. And for adults with initial diagnosis of sepsis or septic shock, adequate source control suggests using, once you have adequate source control, use a shorter period. So shorter is good than to give them. There are times where I've had patients or we've seen patients on weeks and end of antibiotics. It doesn't help. It actually adds on to antimicrobial resistance. And finally, with adults with an initial sepsis of septic and septic shock, when you have adequate source control, where optimal duration of therapy is unclear, we suggest procalcitonin. So PCT again has come up, and you need to know how to use PCT. Unfortunately, from my part of the world, PCT takes about a week and a half. So for me, PCT is not so helpful. All right, thank you.
Thank you so much. That's really great. And yeah, the procalcitonin and lactate and things like that, are often unavailable. And then, as you mentioned, if they are available, they're not available in a timely fashion, enough to make them useful for clinical decision making. That is a lot of information about antibiotics. Antibiotics are an area where people do get confused, and it's very important to do it well because you want to treat the patient appropriately, but you also want to be a good steward of antibiotic use. All of these resources, including the guidelines, are available on the Learning Resource Center and within the resource library on the LRC. So if you want to go back and review those and don't remember all of it, then you can always go back and review again. So Mr. G was started on cefepime, which is considered a broad spectrum antibiotic. He received 2 peripheral IV catheters, and crystalloid fluids have been started, but his blood pressure is still low. His blood pressure is 89/43 now, and that means his MAP has decreased to 58 millimeters of mercury. You want to give Mr. G a fluid bolus, but how much should you give if he weighs 70 kilograms? And I'd like to hear from the panelists. How much would you give Mr. G in Fluids? Dr. Meem, Dr. Pearl?
I'd give 1 or 2 liters.
Yeah.
I think for patients with septic shock, and Mr. G appears to meet those criteria, you want to again give over the first 3 hours a minimum of the first 30 mils per kilogram, which would be 2 liters. I think the speed of it will depend a bit on how low the blood pressure is and how well he responds to what you're giving.
Dr. Joel Yao or Sebastian, how much fluid would you give?
I think I'll give the same, about 30 mils per kg bolus initially, yeah.
Yeah, I think so too. Like 1-2 liters of liquid, and evaluate him as you're giving liquid to see how he responds.
Great.
Say with me, 30 mils per kg over 3 hours.
Okay, great. So we're all saying about the same thing. So 30 milliliters times 70 kilograms would be 2,100 milliliters of fluid for Mr. G. So that's around 2 liters, which is what most of the panelists have said. So let's talk a little bit about fluids and what types to use and how much to give. And I'm wondering, Dr. Meem, would you be able to help us with some of the information?
Yeah, so I mean, the antibiotic intervention is very important, of course, but they're not going to turn sepsis around quickly and the patient's in shock. So we need to fluid resuscitate this patient. And the question is, what fluid regimen should we use? I think we've heard everyone agree on 30 mils per kilo, which is an appropriate. Also, remember that we have his history that tells us he's been NPO for a number of days. So he's dehydrated just on that basis alone. Even without sepsis, he's going to be dehydrated. So
that's an excellent point. That's a very good point.
So be sure that his history is also helpful in telling you additional information about how much volume down he may be. The question is fluid resuscitation good, or is it actually harmful? And it's a little frustrating to hear this news because we all want to give fluid to this patient. And this is the recommendation, of course, and for several studies showing that this roughly 30 milliliters per kilogram starting point is a good one. And this is, evidenced by, you can see the strong, moderate quality evidence that, in critical care, we don't have that many strong, moderate quality evidence published. I don't know if you've taken notice of what the other slides showing, many of them showing weak, low quality of evidence. I think it's pointing out the fact that it's very hard to study patients who are critically ill and get good scientific data to support our decisions. But in this case, we do recommend crystalloids as the first line fluid resuscitation. And the second point is that for adults with sepsis or septic shock, we suggest balanced crystalloid solutions instead of normal saline. And this, as you can see, has been changed from a suggestion that either balanced or saline for fluid resuscitation was okay. That was the past recommendations, and now they've been changed now to avoid normal saline. And it might be helpful for us to just start calling it abnormal saline, because there's nothing normal about normal saline. And sadly, it got its name from a scientist who just did a bad experiment and thought the concentration of saline in human beings was a lot higher than it actually was. So there's nothing normal about it. In fact, it creates all kinds of problems with a hyperchloremic metabolic acidosis. It causes renal vasoconstriction, cytokine release, and there is concern, although there's not
Yeah,
powerful, but this concern it causes acute kidney injury as well.
Yeah, so there have been a lot of unfortunate side effects to receiving saline that we've noticed over the years. I think we have to be somewhat cognizant that in some settings, saline is all that's available. And so if you have to use saline, by all means, resuscitate your patient. But certainly if you have a different balanced salt solution, then try to use that instead.
Yeah, I think one of the more problematic issues with saline is that it causes an acidosis, and you're giving it to a patient who has an acidosis, and you're hoping for a resolution of the acidosis to show that it's the condition of the patient's improving, but you're giving fluid that actually causes acidosis. So I think that's the thing that's always annoyed me once we realized what we were doing with saline. So if you're in a hospital, that's all you have, by all means use it. But I think if you take away anything about fluids from this talk, the sooner you can get some balanced crystalloid solution, that would mean lactated ringers or plasmolite or Normasol, you should get it in your hospital.
I have seen lactated ringers or ringers lactate more commonly in some settings, so that might be more preferable than the normal saline, certainly, and easier to get. Do you have any concerns about fluid resuscitation in children in Africa specifically?
Well, yes. If we go to the next slide, yeah, there are some very concerning studies showing that in low resource settings, just arbitrary fluid boluses across the board may not be beneficial for patients, and has been associated with increased mortality. And so, well, this is very concerning when we know that many patients who are poor perfusion need fluid resuscitation. So and this is also a concern in adult patients as well. The study in JAMA on the lower right that showed a significant increase in mortality in adult patients. So it seems like we just can't just arbitrarily give fluids in patients, especially in settings where we don't have all the other necessary, or what we presume to be readily available support system in support systems in place. For instance, supplemental oxygen, or even high flow oxygen, or non-invasive ventilatory support, or the ability to have the patient intubated with a ventilator. So if these things are not part of the place where you work, then you're unable to support patients who get fluids and may get a little more than they need, and have some respiratory difficulties. In particular, it's the respiratory difficulties that's concerning, because some of these, the study in the lower right eliminated patients who presented with some respiratory distress, and still they had a dramatic worsening of outcome and a high incidence of respiratory difficulties during the fluid resuscitation phase. So it suggested that there is some harm to do with fluids, and the challenge is to find the evidence that this patient of yours, like Mr. G, is really going to respond appropriately to fluid resuscitation.
Thank you. I think I'd love to hear from Sebastian, Joel, and Dr. Yao. My takeaways from the fluid boluses in children is that we really need to make sure we're making the right diagnosis before fluid resuscitation. For example, I think a lot of the children were actually quite anemic because their presenting diagnosis was actually malaria. And then I think in the adult patients, it really goes back to some comments that Dr. Yao made, I believe. You have to continuously reassess the volume status of your patients instead of just giving fluids blindly. So, capillary refill is a good thing to look at in some of the more dynamic assessments. But this is not at all to say that we should not fluid resuscitate our patients. It's really just that we need to do it carefully and deliberately and make sure that we have the right diagnosis. Do any of the panelists have any additional comments in that regard?
Yeah, hi. So there's a comment. I mean, when you talk about in Africa, I think you're talking about the FEAST trial. So the FEAST trial spoke about hypotension, and that's one of the things that spoke about how to kind of manage, the fluid management in children, which is a very good trial. I think I recommend everybody reads it, but it helps you guide you. And another comment I wanted to make was the Rose model of resuscitation. I don't know if you know the Rose model. So the Rose model actually talks about whether you do a 30 ml or 4 mils per kg in 5 to 10 minutes. And I think when I was in training in Tiger Bay, Cape Town, we actually used the 4 to 10 mils over 10 to 15 mils. So the Rose model is one of the other options that you can incorporate. And in terms of normal saline, and I mean, use what you have. Like you said, normal saline is not, you want a balanced solution, but if you're stuck with NS, it's better to give something else, not to give anything at all. So those are my comments and my thoughts. Thank you.
I agree with you. And I have seen more lactated ringers available more often over the years, but you're right. And the mechanisms of acidosis are quite different between the septic etiology and giving the normal saline. So I would probably still advocate for fluid resuscitating the patient, but it is certainly something to be aware of and something that we should know about.
And I just, something very important for children to always monitor the diuresis. The diuresis, it never fails. It's always effective. It helps to really tell if the child is responding well to fluid resuscitation or not.
Thank you. Absolutely.
Yeah, and just to add on to that, I think what's very important what we see here in the lower resource parts in Mexico is sometimes you give the indication of how to have to resuscitate with fluids, but if you don't give the follow-up and if you get distracted by other patients or other work that you have to, then that is the moment when you can have overload. So be very careful when you're indicating these boluses and be able to have to stay or make sure someone is going to stay and monitor constantly that patient to avoid going over the edge or taking too many fluids. But I do think that giving this initial bolus is one of the key points to being able to manage sepsis or septic shock in a correct way.
That's an excellent point, Dr. Sebastian, and I think one that we can't stress enough: continual monitoring of our patients and reassessment. Sepsis is not something where you just do one thing and you're done and the patient gets better. You have to continually reassess those patients. I think that's great. Dr. Mean,
the other thing I would say is you also need to assess whether there's ongoing fluid losses as well. For instance, since someone who presents with diarrhea, if while you're resuscitating them, they have ongoing diarrhea, they're continuing to lose more volume while you're trying to catch up. And so, again, monitoring what your patient is doing in real time is important.
Excellent point. Would you be willing to lead us through this question? I think we actually have a poll for the audience, and some people.
I see the polls going. The question
great.
is, which one of the following is considered a dynamic measure of responsiveness to resuscitation? And I think this gets to the point of trying to do no harm with the fluid that we do give our patients. And so establishing or identifying patients who will or are responding to the fluid you're giving them is important. So you have stroke volume and stroke volume variation, passive leg raise, pulse pressure variation, echocardiography, and a choice of choosing all of them as reasonable ways to monitor or assess a responsiveness. And let's see.
So
when do you
yeah.
want to call that poll off here?
Yeah, I stopped it. Yeah.
Okay,
But
fine.
there was a mix of answers. But I would say all of the above. I think that the stroke volume and stroke volume variation are not as accessible to people with resource constraints, but most of the others I think should be available.
Right. Also, I want to remind you that depending on how I think passive leg raise is a great a maneuver that can be used anywhere, but also realize when people talk about how much volume the patient gets with a passive leg raise, that can be dramatically reduced. If they're very hypovolemic, then there's less blood volume in their legs too. And so it's a smaller incremental volume the patient gets with that leg raise, but it's still something that can easily be done. So the recommendations now, you can see number 6 here for adults with sepsis and septic shock. We suggest using these dynamic measures to guide fluid resuscitation over physical exam or static parameters alone, meaning simply a blood pressure. You can, obviously it's a very reassuring to have the blood pressure improve with fluid bolus, but it's a fairly insensitive measurement by itself. And you'll also notice that all of these recommendations are weak, low quality of evidence. As I was suggesting before, we still are hoping to get better quality of evidence to guide what we do with these critically ill patients. Second point, number 7, is for adults with sepsis or septic shock, we suggest guiding resuscitation to decrease in serum lactate in patients with elevated lactate over not using serum lactate. And again, if you're in a place where you can't get that assay, you might use the serum bicarb and have the serum bicarb improving as a sign that the acidosis is improved. And the number 8 is for adults with septic shock, we suggest using capillary refill time to guide resuscitation as an adjunct to other measures of perfusion. And this is a new recommendation. And I think, again, because it's readily available in any location, just want to remind you that the normal capillary refill time is 1 to 2 seconds. So anything longer than that would be considered signs of poor perfusion. And you just do that by pinching the nail bed until it blanches completely for about 10 seconds, and then you release it. And within 1 or 2 seconds, if the patient has normal perfusion, the nail bed should pink up again. So it's a simple test, but has been shown, as Dr. Yao already mentioned, to be a useful one in septic shock.
Thank you so much, Dr. Mame. I'm keeping track of time, so I'm gonna usher us ahead a bit. Mr. G got his fluids, his crystalloid fluids, his blood cultures, urine cultures, and sputum cultures have been ordered. His blood pressure is still low. So the next question is what do you do about that? What is the first line vasopressor medication to use in septic shock? Do any of the panelists want to volunteer an answer? Dr. Mame, what's your first choice of pressor in septic shock?
I would probably use norepinephrine.
Yeah. So we say norepinephrine. It's also called noradrenaline. That's the first line agent in sepsis and septic shock. And I'm wondering if Joelle can help us with this next learner question.
Okay, the next question is quite important. Again, this is It's important because it is related to the main therapeutic goal of septic shock management. The question is, in patients with septic shock, what targeted blood pressure are you going to go for? Is it a systolic blood pressure greater than 100, a diastolic blood pressure greater than 70, a mean arterial blood pressure greater than 65, sorry, or a systolic blood pressure greater than, 90? So you can
I
give
think
your
the poll has already been opened and answered and closed. So the answer was C, mean arterial pressure greater than 65.
Thank you, Anna. So it's important to see this mean arterial blood pressure is often calculated already on most of our monitors in the intensive care unit or at emergency unit. But if you don't have these, there are also many calculators which should be available online for you to calculate this directly. Anything to add, Anna?
That's great. Yeah. So the next slide, I believe, is Dr. Pearl. No, sorry, Joel. Sorry.
Concerning the use of vasopressor drug, it is important to see the first line vasopressor drug. They want to be used in first intention. In all cases, it's going to be noradrenaline or norepinephrine, depending on where you practice. If this norepinephrine is not available, you can opt for dobutamine or adrenaline or epinephrine itself, still the same thing. It is also important to say that the targeted blood pressure is a mean arterial blood pressure greater than 65 and should be monitored ideally on an invasive arterial line. Vasopressor should be administered on a central IV line. If this is not possible, this should be started on a peripheral IV line at or near the antecubital fossa, only for a short duration of time, with the intention to relay on a central venous line as soon as possible. Generally, you can do that in an emergency setting. You can start on the peripheral IV line with the intention to relay within maximum 24 to 48 hours, not above that. Lastly, vasopressin can be started as soon as the dose of noradrenaline is above 0.25 or 0.5 microgram per kilogram per minute. This is, in other words, a diagnosis of refractory shock.
Thank you so much. I know doing peripheral vasopressors drives Dr. Meem absolutely crazy, but if you don't have a central line or anyone skilled at placing a central line, it is possible to run your pressors through a peripheral IV that's more proximal at the antecubital fossa or higher. I'm gonna skip ahead because we're running out of time because we're having so much fun talking about distributive shock. But Mr. G's very ill. He certainly meets all the criteria for sepsis and septic shock according to any of our early warning scores. His lactate is elevated. His respiratory status is worsening, and the nearest hospital is still a ways away, but they have accepted him for transfer to their ICU. He's received IV fluids. He's been started on a noradrenaline infusion, and due to persistently low mean arterial pressure, vasopressin infusion was also added. So this one is for Dr. Pearl. Some of the learners have asked a few questions about the use of vasopressin. I'm hoping you can walk us through some of the answers to their questions.
So actually, I'm not sure there are clear answers. The studies, there have been two major studies. You'll see the VAST trial and the VANISH trial. They are consistent in demonstrating that when you add vasopressin, and remember that vasopressin does not act the way that almost all the other drugs we're talking about work to raise blood pressure. It's not a catecholamine. It does not constrict diffusely blood vessels. It primarily increases the resistance, decreases blood flow to muscle and to some other tissues, but without the major effect that we have on, for example, the gut or the kidney. And when you add vasopressin, you do see an increase in blood pressure. The studies show the ability to decrease the amount of norepinephrine, noradrenaline that you're having to give. And so the Surviving Sepsis Campaign guidelines recommendation is that for adults with septic shock on norepinephrine with inadequate MAP levels, we suggest adding vasopressin instead of escalating the dose of norepinephrine. The question is when to do it, and in general, most people do it when you get to between 1/4 and 1/2 of a microgram per kilogram per minute of noradrenaline. The other part of the slide is just the VAST trial was a trial that's had lots of subsequent analyses. Overall, there was no mortality benefit. There was some benefit in different subgroups, but not compelling, I would say. And the VANISH trial showed no change in mortality, but there might be less need for needing a renal replacement therapy, such as hemodialysis. So most people nowadays, yes, when you get to high doses of norepinephrine, will add vasopressin, but the recommendation is not to use vasopressin as the first-line drug or the single drug that you use. This next slide talks about what to do if we are already on 2 vasopressors, in this case, noradrenaline and vasopressin, and with a choice of 5 options. Let me first talk about the corticosteroid option. Here, corticosteroids, we're really talking about hydrocortisone in doses actually slightly lower than for adrenal insufficiency, usually 50 milligrams every 6 hours, or an infusion of 200 milligrams a day. Back in the 2016, and I think it will appear there if you click to the next piece of this slide, they recommended the use of steroids in patients who were remaining hypotensive despite vasopressor treatment. In the newer recommendations based on additional studies, the recommendation is to actually start corticosteroids in patients who are demonstrating a continuing need for vasopressors, even if they've responded in terms of blood pressure. But if they continue to require vasopressors, one should be starting corticosteroids. The studies have been relatively consistent in demonstrating that the addition of vasopressors, of corticosteroids in that setting, decreases the time required to wean patients off of vasopressors. It decreases hospital resources. It may improve mortality, though that has been shown in some but not other studies. And they're relatively small side effects. There are some studies that, earlier studies demonstrate increase in neuromuscular weakness, but that really did not hold in the subsequent studies. And the recommendation now is the one you see, number 58. For adults with septic shock and an ongoing requirement of vasopressor therapy, we suggest using IV corticosteroids. So getting back to the question asked here, in reality, probably I would have started them once the patient was continuing to require simply 1 vasopressor, not 2. The other options here, adding an adrenaline infusion, is really for patients where you diagnose that there's significant cardiac dysfunction, either underlying, or patients in septic shock may develop septic cardiomyopathy. And to increase cardiac output, adding epinephrine or dobutamine is not unreasonable. Terlipressin people have used instead of vasopressin, but mainly for treatment of liver failure, and there's no real data to suggest it's used for septic shock. And finally, talking to the family and withdrawing care, it's appropriate to have conversations because patients here on 2 vasopressors do have significant mortality, but many of these patients will recover. And I would say that more of these patients will survive than will die at this point in time, particularly if you're only starting treatment.
Thank you, Dr. Pearl. That was an excellent discussion and explanation. I particularly like how you said that it will save hospital resources, which I think is really important for many of our learners on this session. Again, I'm going to move us along. Mr. G is now on 15 liters per minute of oxygen by mask, but he's still short of breath. He's ill appearing, has increased work of breathing. He's on noradrenaline. He's on vasopressin. He received some hydrocortisone, and his clinical course will be continued. Later in the next 12 months, we will have a session on mechanical ventilation for ARDS and other things, but I want to move us now to a couple other really brief descriptions about distributive shock, specifically with anaphylaxis from Dr. Yao.
All right. Thank you again, Anna. Right. So I'm going to just quickly talk about anaphylactic shock. Again, it's one of the distributive shock, and the mechanism of your reduction in SVR is quite different. And I'm sure most of us would have experienced it. I remember one of my first experience as a resident was to have a patient who had anaphylactic shock whilst on theater, and my consultant really drummed it into my head about giving a test dose of antibiotic. So moving on, you need to be able to pick up the signs when you have a patient anesthetized who has an anaphylactic. You have cutaneous signs, you have cardiovascular signs, you have respiratory signs, and you have GI signs. But when the patient is anesthetized, it's hard to actually, you need to be like Sherlock Holmes, look around and find all these signs. One of the things you see is they'll develop some rash or hives, which are features of the cutaneous signs. They'll develop hypotension, and they will develop tachycardia. They can have bronchospasms. So some of us have had patients who have had bronchospasms whilst under anesthesia. And the thing you need to notice is that it's of sudden onset. Usually, the time between the persistent and the effect is quite short. That's one of the giveaways for anaphylactic shock. I want to emphasize strongly that call for help. Make sure you have your code chart ready. Inform the team and document, because going forward, the patient needs to be like aware of this, of whatever caused this anaphylactic reaction and shock. You might, in some cases, when the patient is so hemodynamically unstable, you might have to pause the surgery. And then one of the things that some of us forget is that, we feel that if it's anaphylactic shock, once you're given your adrenaline, you don't need to do CPR. But at times the patients have arrested, and you need to actually initiate CPR. And you need to look out. The fact that you have electrical activity doesn't mean everything is fine. They might have a PEA, which you might have to intervene. Going forward, you have to discontinue all allergens, and you have to make sure that you stop any drugs. The commonest precipitants are antibiotics, like I mentioned, but the other things, sulfur-containing drugs are one of the key things that you need to look at. And blood transfusion. My second anaphylactic shock was a patient who was being transfused, and she developed obstetric patient. She developed massive anaphylactic shock that we had to manage as well. In some cases, you discontinue the volatile anesthetic agent, but sometimes you might need to give your volatile to break your bronchospasms, but sometimes they cause a hypotension. So it depends on what you are managing or what you are dealing with. You have to always make sure you give your IV fluid bolus. Adrenal and epinephrine is the drug of choice, and it's in escalating doses of 10 to 100 micrograms every 2 minutes until you see clinical improvement. So you keep upping the dose till you see clinical improvement. If you don't have any improvement, you need to continue supportive management. And like we've spoken about, you need to consider vasopressin bolus and add on noradrenaline. And you need to treat your bronchospasm with your SABA. So you can use your salbutamol or albuterol nebulization, and you can add on epinephrine when you're nebulizing that. You might need to, of course, get additional IV access, and you need invasive monitoring just to keep you on top of things, to see where you are when it comes to your resuscitation. You need to also look out for signs of angioedema, which is a very big problem. So you have massive swelling and edema in your airways, and that might require, so if this patient is not intubated, you need to actually put the tube down as quickly as possible, because you are anticipating that things can get a bit pear-shaped. When they are stable, you need to consider. So the thing is, if you look at the pathophysiology of anaphylactic shock, you have massive histamine release. You have that affecting with interleukin and cytokine release, which causes your vasodilatation and reduction of SVR. So therefore, you want to kind of give things that stabilize your bad cells, and that's one of the things is the H2 and H1 antagonist. Now, in terms of the post-event, it's not all okay, you've got the patient back, everything is rosy, you just walk away. You need to kind of, like I said, document the drug, the offending drug, try and find out the offending drug that caused your shock. And you want to also be sure that it was an anaphylactic shock. There's some tests that you do, like your tryptase test, your histamine test. So tryptase is one of the enzymes produced in the granules of the mast cell. So when you have mast cell degranulation, you have tryptase release, and usually it's sensitive after an hour. So you have to try and check for your tryptase within an hour post when you have this anaphylactic shock. And unfortunately, we don't have it in our center. So again, this is textbook for me. But yes, that's what the standard is tryptase. When the other thing you also need to know that sometimes you might have to keep the patient intubated, because I've seen times where patients have had what I call a second hit of after that. Even though you stopped off anything, they go back into that. So sometimes you abruptly stop your adrenaline, or you extubate prematurely, and so sometimes you need to kind of keep an eye on it and be sure that this patient is ready for extubation before you do that. And then often or not, you monitor this patient for at least 24 to 48 hours, and then refer the patient to an allergy specialist to try and find out other things that can cause that, because this could be actually a cross reaction with other drugs and medication. So that essentially is a nutshell for anaphylactic shock. Thank you.
Perfect. Thank you so much. I think it's really important to send that tryptase to make sure it is true allergy, because if it is, then that patient should not receive those medications again. But if you just assume it is, for example, a neuromuscular blocker or antibiotic, then that patient is no longer allowed to receive those. It's important to do that tryptase if you can. And I do think that biphasic reaction you mentioned, Dr. Yao, is really important as well. Dr. Joel, can you tell us quickly about neurogenic shock and how that is another form of distributive shock?
So neurogenic shock is another form of distributive shock. It is mainly due to a spinal cord injury, or can be a compression, or it can be a complete section of the spine, usually around T6 vertebrae or above that. The pathophysiology is going to involve a loss of vasomotor tone with vasoplegia, resulting in hypotension and bradycardia. It is a medico-surgical emergency whose principle of management is going to rely mostly on advanced trauma life support principles. And so we're going to give fluid and vasopressor resuscitation. We may be called to secure the airways, intubate the patient, give oxygen, ventilate. We may have to prevent deep venous thrombosis and pulmonary embolysis, because most of these patients are going to become paraplegic and risk to thromboembolic complications. We have to call the neurosurgeon for a good neurosurgical evaluation in the means to start preparing for a spinal surgery or a neurosurgical operation. And yes, steroids, the use of steroids or administration of steroids is still very contradictory. There's a lot of controversy in the literature concerning that. But usually, when there's going to be a spinal compression with edema, this may have some benefit. But again, it's always good to individualize the treatment. Taking into consideration, is the patient dehydrated? Does he have any renal failure, acute kidney injury due to the paralysis? And that is it.
Thank you so much. Dr. Sebastian, how about adrenal shock and adrenal crisis?
Yes, with pleasure. So when we're talking about adrenal crisis, what we're going to emphasize today is just the acute and emergency management. Defining the cause and why it's caused, it's a topic of its own conversation. So let's just think you do have the suspicion that your patient is having adrenal insufficiency, and you have to divide your treatment in two categories. First, the emergent measurements, because this is a lethal situation that you have to manage as soon as possible. So the first thing you have to do with these emergency measurements is establish large bore or large gauge needles IV axis, 14 or 16 gauge if possible. Draw blood. As soon as you establish this IV axis, try to draw blood to send the results, to send lab studies, but it is very important that you don't wait for these results to continue this emergency measurements. Usually you would ask for electrolytes, glucose, plasma cortisol, and ACTH, as well as blood urea and nitrogen. As soon as you've drawn these blood labs, you have to infuse 1 liter of isotonic saline or 5% dextrose as quickly as possible, and repeat fluid boluses as needed for volume resuscitation. This is one of those situations that we've been talking that you have constant monitoring, and that you can be very aggressive when you're talking about fluid administration. And you have to continue the hemodynamic monitoring as invasive as possible. You can also give, within the beginning of your management, 100 milligrams of IV hydrocortisone, followed by 50 milligrams every 6 hours, to be able to sustain these levels of steroids with a patient that has complete insufficiency or has an adrenal crisis. If we do not have available hydrocortisone, you can also use other steroids such as methylprednisolone and dexamethasone. Use supportive measures as needed. So this means whatever, if you need vasopressor, use vasopressor. If it needs intubation, whatever the patient needs, because you have to manage this acutely. Once you surpass this acute management, this emergent measurements, you have to go for subacute measures. You have to continue volume administration at a slower rate for the next 24 to 48 hours. What's important is now that you have to search and treat. If it's an infection, start with antibiotics as well. Taper in the following days the glucocorticoid over 1 to 3 days. And if patients were already known with primal adrenal insufficiencies, then you can try to, you have to start mineralocorticoid replacement with fludrocortisone as well by mouth daily. And if the patient does not have a known adrenal insufficiency, you have to confirm the diagnosis and determine the underlying cause. And that is a whole subject. And what you have to keep in mind is that that patient has to be studied by specialists or by a tertiary care center. But I think the important thing about the adrenal crisis is the first box of this table, that it's just the emergency measurement and the aggressiveness of fluid resuscitation in case you suspect these type of patients with the mineralocorticoid administration as well.
Excellent. Thank you so much, Dr. Sebastian. I really appreciate it. Normally we would have time now for questions, answer, and discussion, but we are already 10 minutes over. So please accept my apologies that we have gone over. If you have placed a question in the Q&A, we will download your questions, and be aware that 2 of the 12 sessions for the Foundations in Critical Care will be frequently asked questions sessions. So if we don't get to your questions or didn't answer them today, please join us again for one of the 2 frequently asked question sessions, and we will certainly try to answer all those questions. Please join us for session 2 on hypovolemic shock. That will occur on December 18th. All of these slides, all of these resources are available to you on the Learning Resource Center. The link is here. You can also join our community WhatsApp group by scanning the QR code here as well. You will receive an email notification from Stanford's CME office within 3 business days. Using the link to you can complete the evaluation and claim your CME credit. There's not something you need to send out. They will send you an email using the email address that you used to register. I want to again give a heartfelt gratitude to our panelists, Dr. Ron Pearl, Dr. Fred Meem, Dr. Sebastian Mohar, Dr. Yao, and Dr. Joel. And most importantly, and probably above all, I want to thank Alana Shangur, who is our program manager, who really makes all of this possible, from managing our WhatsApp groups to managing the slides to managing our Zoom webinars and live streaming. So thank you so much again, and we will see you on December 18th.
Thank you all. Thank you, Dr. Crawford.
My pleasure.
Yeah. This was fun.
I'm glad you enjoyed it. Thank you, Dr. Pearl. We're super grateful. And thank you to all the learners. I'm going to leave this up just a few minutes longer in case they want to access that QR code for the WhatsApp group. And again, the Learning Resource Center has all of the slides and resources that were mentioned today.